Hello, everyone, and welcome to a talk on POTS and long COVID that I gave for a Tri-Beta meeting. That meeting was not taped, and so I thought I would just tape a version that you could listen to if you like. So many people have divided their life sort of pre-pandemic and then post-pandemic, but for my family, our life was divided from before my daughter developed POTS and then after. And you can see, like many young families, we were doing all of the sort of normal things and everything was great. And then my older daughter turned 10 and got sick with what we thought was mono and never got better. And so that moved my family really into the chronic invisible illness community. I think a lot of you know what this means already, but I'm going to say it anyway. So chronic means that it's not something you recover from in a couple weeks or a couple months, but it's an illness that is debilitating for years to decades, but typically is not fatal. Invisible, I think, is twofold. One is that when you look at someone with POTS, on the outside they look healthy and fine, but on the inside they feel absolutely awful. The second part of that, though, is that when a healthcare practitioner goes and does testing, they don't find anything. So they can run blood tests, urine, imaging, and all of that comes back normal. And when you put those two together, it takes a long time from the onset of symptoms to diagnosis. And so the average right now is about 2 years. That's improving, but we still have a long way to go here. And then finally, the illness part is real. The average POTS patient has 16 different symptoms that cross a variety of organ systems. And so we're talking about really debilitating illnesses. So after my daughter developed POTS, it changed her life, of course, but it really changed the life and trajectory of my entire family. And certainly I wouldn't be recording this talk for you today if my daughter had not become ill. So what is POTS? Turns out that it stands for postural orthostatic tachycardia syndrome. It's the most common form of dysautonomia. And dysautonomia literally means malfunction of the autonomic nervous system. And the autonomic nervous system is your automatic or your involuntary part of that nervous system. And it controls a lot of things that we rarely think about, but that are actually quite important. And so if we can't test for this with blood or urine tests or imaging, how do we know if someone has POTS? And the answer to that right now is the tilt table test, which is stressing that autonomic nervous system and seeing how it responds. And so many of you may have done this already, but I'll say it again anyway. You lay flat on the table in a horizontal position for at least 10 minutes. Often it's 20 or 30 minutes. And they hook you up to all sorts of monitors, and they're watching your heart rate, and then they measure that blood pressure every 2 minutes. And then they elevate the head of the bed to 70 degrees for up to 10 minutes, and they're watching those vital signs. And what they want to see is that the blood pressure stays relatively stable and the heart rate jumps up by 30 beats per minute for an adult or 40 for an adolescent. In my daughter's case, it went up by about 72 beats per minute and stayed there until they put her down. In addition to that, she became very symptomatic. She was hot flashing and she was feeling very nauseous. And as terrible as it sounds, I felt really excited about that because I knew that we were close to an answer. Finally, we were going to get her diagnosed. So it sounds a little strange, but I think this is a group that probably understands that. So again, that tilt table test is really checking to see how well you do with orthostasis, which is standing up straight and still. And so orthostatic intolerance, the inability to stand up straight and feel well, is one of the primary symptoms of POTS. And so when a person with POTS is sitting or laying down, their heart rate is normal. So it'll be in that range of 60 to 100 beats per minute. And their symptoms are actually reduced. They feel better sitting down or laying down than they do standing up. When they stand up, we just talked about, they see that increase in their heart rate, but the symptoms increase there as well. So the question is, why does that happen? And so what I'd like to do is start in this graphic in the brain area. And of course, there are two parts to the autonomic nervous system. There's the sympathetic nervous system, which is your fight or flight system, and that uses the neurotransmitter called norepinephrine. And then its opposite is called the parasympathetic nervous system, and that's the rest and digest system. So the sympathetic nervous system is helping the body when you stand up to deal with that stressor. And so the norepinephrine is going to target a lot of the blood vessels, particularly down in the legs and the abdomen. And it tells them to constrict, to get smaller. And the idea, normally, that's what it's normally supposed to do. And the idea is that that forces the blood back up towards the heart and the head. Well, in people with POTS, it doesn't work. And we'll talk about in a few minutes why it doesn't work. But the blood vessels still stay pretty dilated. And as a result of that, you get blood pooling down in the legs and also in that abdomen area. So the whole blood volume is sagging in the body. It's being pulled down by gravity. And what that means is that we don't have enough blood left up here in the head and in the heart. And so in the head, you start seeing brain fog, dizziness, lightheadedness, headaches, all of those things as that blood flow decreases. For the heart part of this, the heart is getting what we call poor venous return. What that means is not enough blood is coming back to the heart. And so the heart responds to that. So we come back over here, and one of the ways it responds is tachycardia. So it increases that heart rate, trying to push the blood faster so more blood comes back to the heart, increase that venous return. And then it also increases the force of contraction. And so the heart is in distress, and so that causes the sympathetic nervous system to release more norepinephrine. And you can see how you get into this vicious cycle that, again, includes the increased symptoms as that person is standing. So that's pretty well worked out. We know that that happens. The next question is, why does that happen? And that's where things get a little bit more difficult. There are 4 leading hypotheses for what's leading to that orthostatic intolerance in folks with POTS, and all of them may be true. They may be overlapping. This is the part that still needs a little bit of work. So let me walk you through them. The first one is hypovolemia. That means low blood volume. And so Dr. Raj did a study back in 2005 where he measured the blood levels, the plasma levels, in people with POTS versus controls. And the people with POTS had 13% less plasma than the control group. They also had a lower blood cell count, red blood cell count. And so you put those two things together, and that leads to that hypovolemia. And we know that everyone with POTS is encouraged to increase their salt consumption and increase their hydration as a way to combat that hypovolemia. Many in the POTS community are familiar with the term hyperadrenergic as the hyperadrenergic form of POTS. Adrenergic is really referring to norepinephrine. And hyper means excessive, right? Hyperactive, you've got too much energy. And so if people with POTS are in a hyperadrenergic state, that means that sympathetic nervous system, that fight or flight system, is in overdrive. It's working too hard. And during the tilt test, many times they'll hook patients up to an IV where they can actually take blood samples at clinically significant times. And what they're doing is they're measuring the amount of norepinephrine, that neurotransmitter of the sympathetic nervous system, in the blood, in the plasma. And if that goes above 600 picograms per milliliter when that person is upright, we say that they have hyperadrenergic POTS. Okay. The third one, I think also a lot of people in the POTS community are familiar with. This is related to small fiber neuropathy, if you've been diagnosed with that. And that is the idea of autonomic denervation. And that's where we have damage to the small nerve fibers of the autonomic nervous system. And we know that that happens, excuse me, particularly in the legs and in the abdomen. And so as a result of that damage, we see decreased levels of norepinephrine, and that's supposed to help us with that vasoconstriction, right, to force the blood back up towards the heart and the brain. And so we don't see that as well. So that leads to that blood pooling that we were talking about just a minute ago. So those three are well known and often overlapping. The fourth one also, there's growing evidence that at least in some folks, POTS might be an autoimmune disorder. Now, I don't think any of the big specialists are ready to say that yet, but there is a substantial amount of evidence building that points to that direction. So we know that about 47% of people who develop POTS get it after an infection, like COVID or mono or Lyme disease, or as a result of vaccine injury. And let me say that that 47% is a pre-pandemic number. It's likely higher than that now. And then also, we know that people with POTS can develop autoantibodies. And an antibody is part of the immune system, and that's a good thing. That helps us to fight bacteria and viruses. But auto means self, and so that's when the antibodies start attacking your own normal body tissue, and that's not a good thing. And so we know that there are quite a number of these autoantibodies that have been identified now, and many people have at least one of those in the POTS population. Let's bring in long COVID here a little bit. And as you scan the numbers, you can see that both POTS and long COVID are higher in women than in men. We're looking at young women in particular. But let me say, this can also be in men, can also be in older people, absolutely. Both of these can be found post-infection. And there are some symptoms that are different, that are specific to POTS only or to long COVID only. But the ones that I really want to focus on are in the middle of that Venn diagram, where we're seeing a lot of sharing of symptoms between POTS and long COVID. So when we look at some of those neurological symptoms, we see things like brain fog, where the person has a lot of trouble concentrating, paying attention, really just processing what's going on in their environment. As they stand up, that dizziness, we've talked about that a little bit already. And there's a lot of pain, literally, that goes into both POTS and long COVID. It could be joint pain, muscle pain, headaches, and migraine headaches are common, and chest pain. We also see depression and anxiety, but just a note here that in POTS, the levels of depression is no higher than the general population. And for those that have depression, it's actually usually mild or moderate. It's not that severe or extreme depression. So it's more a symptom of the disorder and not the cause of the disorder. So I want to be clear on that. When we look at the cardiovascular system, people with POTS and long COVID both develop that tachycardia, that fast heart rate at rest, as well as heart palpitations and shortness of breath. And then we also see real issues with sleep and fatigue. And I really want to point out this post-exertional malaise, which is a rebound fatigue. And so if someone that you know with POTS or long COVID comes to a gathering for you that was important to you, they may not be, the center of attention or standing in the midst of everything. They may be sitting in a quiet corner. But please know that they know that they're going to pay for that they're going to have a rebound fatigue that may put them in bed for 2 or 3 days or longer than that. And so that's that post-exertional malaise. So take that as a real honor that they made the effort to come to your gathering. Let's look at this a little bit more. When we think about long COVID, the Centers for Disease Control have said that 1 in 13 people in the United States now has long COVID. That's about 7.5% of the population. And that's coming from a variety of different areas. So when you look at people that had severe COVID, that were hospitalized for that COVID, 50 to 70% of those cases develop long COVID. When you think about those folks that were able to deal with COVID at home, they had mild or moderate cases, they had maybe cold or flu-like symptoms, 10 to 30% of those go on to develop long COVID. But that's actually the majority of long COVID cases now, because there are just so many millions of people that have had those mild and moderate cases. And then unfortunately, we are welcoming way too many people into the POTS community from the long COVID community. And 15 to 50% of folks with long COVID go on to develop POTS. And so there was a study just at the end of 2022 that compared comorbid diagnoses for people with long COVID. And what they saw was that the number one disorder after a COVID infection was diabetes, second was POTS, and third was hypertension, which is high blood pressure. When they looked at people that got long COVID from the vaccine, so a result of vaccine injury, number one was myocarditis, which was in the news a couple of years ago. Number two is dysautonomia and POTS. And number three is mast cell activation syndrome, which I'm going to come back to in a second. So this graph over here is from that paper. And so on the x-axis, you have the odds of diagnosis after long COVID or after COVID versus before. So the further you are to the right, the higher the odds are. And on the y-axis, you have the rate of new diagnoses after COVID or vaccine. When you look at the colors, that golden color is after an infection, and the vaccination would be blue color. So we have the highest odds and incidence up here in this upper right-hand corner, and you see that POTS is up there, so I put the red bars next to the ones that I wanted you to be able to pick out here. We see dysautonomia over here to the right, and mast cell activation disorder down here as well. And so this is important for the POTS community, and in thinking about the connection between long COVID and POTS. So what I'd like to do is think about what might be causing some people to develop long COVID after a COVID infection and other people don't. So let's say a whole family has COVID, just moved through the household, and one of the people in that family develops long COVID, but no one else does. Why is that? If the illness level was about the same, why is that? And what I'd like to propose to you today is that maybe mast cell activation syndrome is the missing link. So let me start by talking about what mast cells are. These are cells that are like the guards of your castle. So if your body is your castle, the mast cells are the guards. Well, where do you put the guards? You put them where they're sort of looking out into the distance, looking for a potential attack or potential danger. And that's where the mast cells are in the body. They're in the skin, they're in your mucous membranes, they are in your GI tract, they're in your urinary system, They're at the blood vessel walls where we've got lots of diffusion going on. So any place that the body interfaces with the environment, we're going to find these mast cells. Now, the mast cells don't look like much, but they're quite complex. And the leading mast cell activation folks think that they can release more than 1,000 different mediators depending on the situation. And so they can release things that maybe we've heard of, like histamine. So maybe some of you are taking antihistamines for allergies. Heparin is a blood thinner. Tryptase we hear about just if you're doing tests sometimes for mast cell activation syndrome. They'll look for elevated tryptase levels. Although a lot of the leading mast cell physicians don't think you need elevations in tryptase to actually have mast cell activation syndrome. And then they can also release chemokines and cytokines, which I'm going to come back to in a minute. Interestingly, these mast cells have on their cell surface the ACE2 receptor, which stands for the angiotensin converting enzyme 2 receptor. And what's interesting about this is the way that the COVID virus actually gets into and takes over your body cells. So it's the principal receptor for what's called the SARS-CoV-2 virus. This is what most people call the COVID virus, but the scientific name for it is SARS-CoV-2, so that's the COVID virus. So that's interesting. We know that the COVID virus can get into and perhaps take over these mast cells. We know that medications that can stabilize mast cells help to improve symptoms or decrease symptoms in people that have long COVID and also POTS. So some of these might be antihistamines. Quercetin is an over-the-counter supplement that's a mast cell stabilizer, or in some cases the physician will prescribe cromolyn, so that's by prescription only. Another piece of circumstantial evidence here that connects these mast cells to POTS and COVID is that MCAS, or mast cell activation syndrome, is a lot more common than people might think. And a study in Germany showed that 17% of that population actually had MCAS, even though they may not have known it. And that really corresponds with the prevalence of folks that developed the severe COVID that needed to be hospitalized, especially before we had the vaccines. And so that was 20%. So the numbers are very, very close there. Again, that's circumstantial evidence, but it certainly is interesting. So let's talk about more the relationship between this COVID infection, the SARS-CoV-2 virus, and mast cells. So we know that the virus, that SARS-CoV-2 virus, can get into the mast cells and that they can cause dysregulation of those mast cells. Now remember, these mast cells are part of your immune system. Their job is to activate nonspecific defenses like fever and inflammation, as well as your specific immune defenses like cellular and humoral immunity. So when it gets dysregulated by this virus, it can really wreak impact on the immune system. They help to recruit immune cells into the inflamed tissue, which in COVID often starts at least in the lungs. And then these mast cells can release those cytokines and chemokines. And you might remember a couple of years ago, cytokine storms actually made the news for a couple of months, actually, as they realized that a lot of people with severe COVID had these huge cytokine storms, and they were struggling to try to figure out how to stabilize those. So these cytokine storms are sort of a double whammy. They can activate or kick up the level of metabolism in these mast cells. But remember that the mast cells can also release them. And so we get into that vicious cycle again. They also activate another immune cell that's also not very well known. It's called microglia up in the central nervous system. The cytokine storms, though, can also damage stem cells in your body. And once those get damaged, every time they divide and give rise to daughter cells, those daughter cells carry that mutation. And so that can also be quite problematic. And then the last thing that we know is that a lot of times people with COVID, so you can see down here at the bottom, 20% of people that were hospitalized with COVID that had serious cases and recovered, or fatal cases, were found to have these autoantibodies, the ones that attack your own normal healthy tissue. And we know that those autoantibodies can also react with these mast cells. So the point is that we know that the COVID virus can interact with these mast cells and wreak some havoc there. Okay, last piece of sort of circumstantial evidence where we don't have a smoking gun, but at least we're getting some dotted lines connecting these things together. And so I'd like to show you these web plots. I love this. I had never seen this kind of graph before Dr. Weinstock's paper, but I really love it. So here's how it works. Think about the periphery like a clock. And so he's got the same symptoms going all the way around the outside of the clock in the same order. And then the web is in the center would be no symptoms at all, and as you move out to the edges of that web would be the highest level of symptom load. And so in this top one, he's looking at just controls, people from the general population, and asking what their symptoms are. And then at the bottom, he's asking people that developed long COVID to remember what their symptoms were like or what their life was like before they got COVID. And look how similar. They're not exactly the same, but they're pretty similar, right? And then he compared people that have mast cell activation syndrome with those that have long COVID. Same idea. So these folks with MCAS, they've just been diagnosed. They haven't started treatment yet. And so you're looking at sort of that pre-therapy symptom load. And then he's asking the same questions in people that have long COVID. And again, when you compare these, they're not exactly identical, but they sure are close, right? Very interesting to think about. When we think about POTS, there was a study a couple of years ago that showed that 42% of POTS patients show at least one marker of MCAS. And another study showed that 89% of people with POTS have at least one of a wide variety, frankly, of autoantibodies. And so again, that sort of ties together this POTS, long COVID, and maybe the missing link is that mast cell activation syndrome. It's interesting to think about. This was a really long explanation, though, to really say we don't understand the underlying physiology of POTS or long COVID. And because of that, medication and treatment is a real problem. And so right now we use a whack-a-mole approach where we go after individual symptoms, but not after the underlying cause because we don't have that nailed down yet. And so if a person's primary symptoms are that tachycardia and heart palpitations, we might give them a beta blocker, right, to decrease that heart rate. If they have hyperadrenergic POTS and a lot of those kinds of symptoms, we give them medications to decrease sympathetic tone. And so my daughter actually, as an example, takes one medication that increases her parasympathetic activity and another one that decreases her sympathetic activity. And you get the idea, right? So we're going after these various symptoms because we can't sort of nip it in the bud, because we're not going after the underlying cause. A lot of times these treatments are hit and miss and they're not very effective. And so that leaves people, even after they've been properly diagnosed, with a decrease in their quality of life for people that are in the POTS community and in the long COVID community. And so with long COVID, we don't have as much research, even though it seems like the pandemic has been dragging on forever. In science, 3 years is not very long, and so it's going to take some time to really figure out what's going on. But one study that came out at the beginning of 2023 suggested that of those that could work after long COVID or with long COVID, 45% of them needed a reduced work schedule, and that 22% were so medically disabled that they were too sick to work. When you look in the POTS community, there was a study a number of years ago that found that 25% of folks with POTS were too sick to go to work or school. And then a study that I did with my friend Jill Brooke found that 30% of people with POTS are in need of help with activities of daily living. So that could be cooking or shopping, bathing, things that we don't usually think about as problematic for people that are in their 20s, 30s, and 40s. What we also saw in that first survey was that 48% of people who responded reported thinking about suicide. And we knew that suicidal thinking was in the community from what we saw in support groups, and that's why we threw the survey in there. But we were shocked at how high the number was. And so that put me into a rabbit hole for 5 or 6 years, really trying to understand why the suicidal thinking is so high in this chronic invisible illness community. And I did a lot of reading of the literature, and the theory that I like the best is called the interpersonal theory of suicide, coming out of Thomas Joyner's lab in Florida. And it was not created for people with chronic illnesses like POTS or long COVID, but I think it fits really well. And there are 3 parts to his theory. The first one is perceived burdensomeness, and he defines that as feeling like a burden to your family or friends. So remember, if you've got relatively young people needing help with their activities of daily living, they feel like they can't contribute at work or in the home in the ways that they did before they were ill, that could increase their perceived burdensomeness. And so we found that this was elevated in 33% of POTS patients. The second part of this theory was thwarted belongingness. And I think all of us at some point feel like an outsider in a social group. But this is really exacerbated in this chronic illness community, where a lot of folks, because of their illness, may stay at home more often, and so they have less opportunities to socialize. And even when they do, their life experiences are so different from other people, healthy people, that it's hard for them to connect. And so 71% of our POTS patients reported high levels of thwarted belongingness. And notice that when people are high on both of these, that can increase that suicidal thinking. And then the third part of this theory is fearlessness about death, which also is what it sounds like, that if people have all of these physical symptoms, but maybe they're not believed because they look okay on the outside, there's a lot of suffering in these communities. And when you've got that kind of suffering, death may not feel as scary as it does if you are healthy. And so it's a very interesting theory, and I really wanted to see how this applied in our chronic invisible illness community. And so what we found was that perceived burdensomeness was a more important risk factor for suicidal thinking and behavior than depression, thwarted belongingness, loneliness, and then also physical factors. And so I want to focus on the depression. This was really the big finding of this study. When we think about depression, we think that a small percentage of folks who are depressed are suicidal, right? But if you flip it, I think most of us think that 100% of people who are suicidal are depressed, right? But what I'm here to say is in this population, in this chronic invisible illness population, perceived burdensomeness was a better predictor of suicidal thinking and behavior than depression. That's a huge finding. And so then the question is, okay, what's driving perceived burdensomeness? What can we do about perceived burdensomeness in this community? And so that was the next study, and this one came out just at the beginning of 2023. And we found that there were some things that seemed to predict perceived burdensomeness. So when we compare men with women, both of them are high on perceived burdensomeness, but men score even higher than women on that survey. And when we think about it, and we think about our gender roles in society, maybe this makes sense, where we put on men that they should be strong, they should be independent, and they should be the breadwinners of the family, right? They should be bringing in the money. Well, what if a guy develops a chronic illness that takes those things away? If we as society are putting those burdens on them, that's going to increase that perceived burdensomeness. So I'm here to say we need to take that gender stereotype down all the way, right? We need to change that. The other two I don't think are surprising. As people had increased illness severity and got diagnosed then with more comorbid diagnoses, the perceived burdensomeness scores went up as well. But what I really loved about this study is that a few things popped as protectors against perceived burdensomeness. So remember, perceived burdensomeness is predicting suicide and suicidal ideation. And so protectors are increased age. So as people get older, their perceived burdensomeness scores dropped. And so that's a good thing. It could be that they're developing more coping skills. It may be that they've got a bigger, better social network that accepts their illness and allows them to feel more seen and understood. But as people get older, the perceived burdensomeness scores seem to go down. The other two, again, I think are less surprising. Psychological health and social relationships are good things for everybody, and those decrease perceived burdensomeness and then also decreased the risk of suicidal thinking. What I love about this idea of perceived burdensomeness is that this is something that we can move the needle on, and we can move the needle in a way that's easier than with depression. Remember that perceived burdensomeness is a feeling like you are a burden on your friends and your family. And so what we need to do is be aware of that and try to decrease that feeling of burdensomeness. So I would suggest that counseling is really important for everyone that has one of these chronic invisible illnesses. And that's not because I think that folks are depressed or anxious. It's because I think that their reality is changing in a really radical way. And they need new tools in the toolbox. They need to learn coping skills so that as people ghost out of their lives, as maybe they lose their job or they can't attend school in a traditional way, that they can deal with that. They may have friends or family who don't believe them. Again, the invisibility of these illnesses make it very, very difficult for the person who is struggling with that illness. So counseling can be really, really helpful. Family and friends, though, can also help to decrease this feeling of perceived burdensomeness. Trying to develop a family structure that allows autonomy when possible. If they're having a good day, let them do what they want to do or what they can do. But when they need help, do that gently. Do it with compassion, right? And then just to check in. So extended family or friends, send a text or ask if they want a FaceTime or if they'd like to have you come over to watch a movie or play some cards. That can make a huge difference for someone who's living in a chronic invisible illness community. Let me just say a word before I move on here. My daughter has been sick for 11 years at this point, and I am not perfect. Nobody is perfect. And all that you can do is the best that you can do in that moment. But I think setting the intention to do your best, to be calm, to be gentle, to be compassionate is a really good thing. So forgive yourself when you have a bad moment and just try to work again toward that calmness and that love. I would also suggest that career choices may have to change. And so for my daughter, she got sick when she was 10. She chose a career that is sedentary. But for people that get sick a little bit later in life, they may need to do some career retraining. Because people in these communities, standing is not their friend, right? It's almost like they're allergic to gravity, right? They don't stand well and feel good. And overall stamina is a real problem for folks with POTS and with long COVID as well. So any kind of job that promotes flexibility, that allows them to sit and work, is a really good thing. It allows them to be productive members of society if they're well enough to work, but also can help protect their health and protect them against symptom flares. So flexibility can be wonderful. And then finally, I would suggest that we need practitioners to screen for perceived burdensomeness when people come in for their regular visits. This is something we can move the needle on. So add one of these questionnaires to that list of questionnaires that you're already giving to people when they come into the office. So this is my summary slide. Thank you for staying with me for this long in the talk. There are a couple things that I hope you take away from this. 1, POTS and long COVID are both chronic invisible illnesses, and we need a lot more research to really understand what's going on here. Until we understand the underlying cause, we're not going to have better diagnostic criteria, and we're not going to have more effective treatments. And so we need that work to be done so that we really can move that needle in medicine to help folks feel better and get rid of some of those symptoms in a better way. Second, POTS and long COVID negatively impact quality of life, even in young people. And it's real, even though you can't see it by looking at them on the outside, their symptoms are real. And their symptom burden goes across several organ systems. And remember, we talked about those activities of daily living can be quite difficult. And that both in POTS and long COVID, about 25% of the population is so sick that they fall into a category of being medically disabled, where they're too sick to work or to attend school. And then finally, more work needs to be done to try to alleviate those feelings of perceived burdensomeness, particularly in young people and in men, right? Remember that perceived burdensomeness, feeling like a burden to your family and friends, is more predictive of suicidal behavior than depression. Okay, so being intentional in your communication, thinking, boy, I haven't heard from that person in a while. I'm going to just text them. And frankly, they want to know what's going on with you. Don't feel bad about that. But just hey, how are you doing? I'm thinking about you today. I hope you're having one of your better days today. Or if you know they've been in a symptom flare, I hope you're getting back to your baseline, sort of a thing. And then those coping skills, I think, are critically important. There is so much that goes on when people develop one of these illnesses. The changing reality is a huge shift. And being able to build those coping skills, I think, is really, really important. So thank you for sticking with me in this talk. Go out and be kind. And please remember that you just don't know what someone else is dealing with. I hope you have a great rest of your day.